We will go ahead and get started. Hello again. This is Lisa Letourneau with Maine DHHS. Thanks everyone for joining. Happy good start to a better new year, and thanks for taking the time to join us this morning. We will be recording the call this morning, so if anybody objects to that, please feel free to go ahead and sign off right now. And I'm going to start screen sharing. We're going to move back and forth a little bit between myself and Dr. Steve Sears from Maine CDC, and then also Dr. Amy Madden from HealthReach and the Maine Medical Association. So those who have been with us before, there's information we'll be repeating. We'll try to go quickly. One, though, is a new one in terms of how to get CME credit. So to try to just keep the chat a little bit neater, we're actually asking you to just email your name and the session you've attended to this new email, covidcme.dhhs@maine.gov. And that way it'll go directly to a person here who will track it. And then after a month or so, we'll be emailing you with a sum total of the sessions you've attended, ask you to complete a small evaluation, and then get you the CME, which again, MMA has been a fantastic partner at providing with us. So that's new. If you've already put it in the chat, if you could just plan to email it directly, we'll just try to keep the chat box a little bit clear for questions. We do not have any disclosures to, financial relationships to disclose. We have a wider curriculum, and in each one of these brief sessions, we try to tackle a few key topics with some overlap from previous weeks. But again, we try to rotate and advance the content, trying to address some of the key issues and questions that come up. So this time I'm going to start just a little bit about vaccine distribution. This is probably not a great forum to talk about it for very long or to try to address a lot of questions. I know many of us get many emails in our inbox every day. We try to do our best, but just as a reminder to folks, the Advisory Committee on Immunization Practices nationally advises US CDC, which then advises the states. It's up to each state to make their decisions about how they phase distribution or prioritize distribution to different groups. This is the phase 1A, 1B, 1C that the state of Maine has adopted to date. There's ongoing considerations and discussions, but right now the focus is really on phase 1A for the continued month of January, which is all healthcare personnel and the staff who help support them. This slide is new to the group, recognizes that we really started that on group 1, which started with hospital personnel, but this past week was extended to medical practices as well. So that's where the focus for vaccination is this week. It will be moving out successively to continue to include others in the healthcare personnel phase 1A. Others have been very interested in phase 2, which is other patient-facing or providers or staff who have potential or real contact with infectious materials. And that includes many of the other healthcare personnel, including behavioral health, dentists, school nurses, et cetera. And then it would be non-facing in terms of group 3, phase 1A, before we then move to the wider population of 1B and 1C, and then eventually phase 2. So again, probably not the best call because we don't want to take away from other clinical issues, but I know there are always a lot of questions about where's the state going on this, what can we expect? Healthcare personnel should expect an opportunity to access vaccinations sometime in the month of January. More details to come. With that, I'm going to turn it over to our clinician expert here on vaccines and immunology. So Dr. Sears.
Great, great. Thank you, Lisa. And I'll just go quickly through what we have already seen and talked about before. But we know these two vaccines, both the Pfizer and the Moderna, are what are known as mRNA vaccines. What happens basically is a little bit of mRNA that codes for the spike protein of COVID is packaged, it's injected, it goes to our cells. Our cells take up the mRNA and in the ribosomes make the spike protein, which is then presented outside to our immune cells, which make an immune response. They have been rigorously tested. We've gone through that. They've gone through phase 1, 2, and 3 trials, and they have been shown to be really quite effective and overall generally safe within the timeframes that we know. These are new technologies in that, in the sense that this is the first time we've given an mRNA vaccine to humans. They have been given to animals, and they've been worked on for probably 15 to 20 years overall. So they've been coming along in technology. They do not contain live virus. They don't carry any risk of disease in the presenting individual. They're really just this little chunk of mRNA, and it does not go into our DNA, and it does not change things around. And as far as our genetic code. Next slide, Lisa. Or can I do that? Okay. They're very remarkably similar vaccines. The Pfizer vaccine was got an EUA, emergency use authorization by FDA 1 week before Moderna. Moderna came out very soon thereafter. They both had big trials of between 30 and 44,000 people. Their efficacy showed very similarly to around 94 to 95%. The adverse reactions were similar, which for the first dose, relatively few side effects. When we get to the second dose, there's a little bit more described in the literature of headache, aches, muscle aches, kind of feeling punk for a day or two, and then that goes away. The Pfizer vaccines being given the second dose at 21 days. We're already starting that because 3 weeks ago we started the vaccination in the healthcare systems, and we're now doing the boosters. Moderna is at 28 days. Slight difference in who it's authorized for. The big problem, I think we've all heard, is that the Pfizer needs to be stored at -70 degrees. That requires an ultra cold freezer. Not so much for the Moderna, can be in a regular freezer and a regular fridge. Next slide. People ask a lot, what else is in this vaccine? Okay, so we know it's got mRNA, that's messenger RNA, that's the nucleoside, modified mRNA, just a little chunk. It's wrapped in some lipids. It's called a liponanoparticle, and that really is like, it's, as you can see, it's phosphocholine, cholesterol, and some other lipids. There is some polyethylene glycol, a very small amount, and salts and sugars. It does not contain, I think this is important if people start asking the questions, that it's not a live virus. It does not contain thimerosal, which was something that was of concern in prior vaccines. It does not contain mercury. It is not made in fetal cells. And it does not contain pork products. So a lot of things that might have concerns to various groups, this does not contain that. It's some chemicals, the mRNA wrapped in some a small amount of lipids, and that's it. It is been remarkably safe, but there has been very observed cases of anaphylaxis. I want to emphasize that so far these are relatively few. There have been 6 cases of anaphylaxis that have been described through VAERS. There were 2 more that we know about in England. So it can happen. It usually happens in people who have very severe underlying allergies, and most of the people who've had the anaphylaxis are those who use EpiPens, but it means you need to be prepared to manage anaphylaxis. I think it's also important to recognize if someone has a type 1 hypersensitivity reaction to the first dose, they shouldn't get a second dose. And that's CDC has come out and strongly emphasized that. So if you are going to be providing these vaccines, make sure that you're ready for anaphylaxis. And with that, I'm going to turn it over to Amy to talk about actually how do you prepare for this in your clinic.
Yeah, great. Thanks, Dr. Sears. I'm Amy Madden, and I'm a family practitioner, geriatrician. I work for HealthReach, which is a federally qualified health center. We have 11 health centers across central and western Maine. So this is our sort of bread and butter here. And as you can imagine, the Moderna vaccine, which is what we just received yesterday, is a lot easier to manage. The nice thing about when you receive the Moderna vaccine is it comes with a lot of information, including a much more more sort of self-explanatory sort of pictograph of how to store and handle the vaccine, as opposed to sort of the long, 10-page vaccine requirement component. But the Moderna vaccine is much more similar to the other vaccines that we typically handle, and so outpatient practices are very familiar with this. I would just encourage everybody to review that information, particularly prior to getting the vaccine. The other thing is just, I think that this rollout has really kind of, made us look at what we have for standing orders, as far as Dr. Sears was just mentioning, preparing for any sort of anaphylactic response. I just want to sort of go back and reinforce that, not to minimize the experience of people that have had it, but it's a very rare situation that it occurs. But being prepared for it, obviously, with low frequency, high acuity events, being prepared is obviously what you want to do. So having a standing order for anaphylaxis, I think, is very important. As we went through and looked at ours, we recognized that the place from which we order our EpiPens actually was having a shortage. And so we wanted to, sort of look around, make sure that we had some other access. The other thing that's, I think, important is just making sure that you have your, what you need for paperwork. So obviously a consent form. We're using the pre-vaccination checklist from the CDC, which I think is quite useful. And that's actually on one side of our consent form, and the other side is the actual consent. That is easily accessible through the CDC website, and walks you through a list of questions that are important to ask prior to vaccinating someone. You'll also get, with your vaccine, you'll get the EUA that's required to give to vaccine recipients. So this is the replacement form for the VIS statement that we typically would give with vaccines. The Maine CDC, and of course nationally, we're required to document that we've given a vaccine within 24 hours. This is within IMPACT. In outpatient practices, we use IMPACT all the time. So this is, of course, not a new thing at all, but getting it in within 24 hours is the important piece. The vaccine also comes with a second dose reminder card. What we've been doing is looking at, obviously when we give the first dose, scheduling a person for the second dose as well, and writing that down on the card itself. There's a nice picture, and making sure that we're set up for that. I think one of the challenges that we're sort of working through and have had to work through in preparation for receiving the vaccine is, basically flow and throughput. Most outpatient practices don't have a lot of excess space, and you need to have space in which you can observe folks for 15 minutes with just national, sort of normal precautions, and then 30 minutes if there's any consideration for a history of anaphylaxis or anaphylactoid reaction. So that's the kind of thinking, I think, as far as, just how you use your space and your staff. The one other thing that I would just put out there that we've, been thinking about is just, this is kind of a, practice as you play sort of situation. So as we're vaccinating our staff, we're also looking at it sort of with a critical eye as far as, how would this play out as we start thinking about vaccinating our patient population, and thinking about what that could look like. So the one other piece that I would just throw out is, if you're a small, we have 11 health centers. Our staff can be quite small. We're trying to vaccinate staff in across a wide area. So that's requiring us to really coordinate how we're giving the vaccine, because there are 10 doses in each vial, and we don't want to waste any. So just, thinking ahead a little bit as you go to vaccinate your staff, if you do have several sites, that's probably going to require some coordination. So.
Great, thank you so much, Amy. And with that, we'll go back, maybe Steve, to talk just a little bit about adverse reporting, which will also clearly be an important responsibility for any vaccinator.
Yeah. If you don't know about the VAERS system, VAERS, you see it right here. That's a link. That is the federal reporting system that takes any and all considered as adverse events and catalogs them, and it's really part of what we call phase 4 testing. So once a vaccine is out, that's just, the first part of the safety data was just that. We really want to continue to collect anything that is an adverse event. All of the anaphylactic and anaphylactoid reactions really need to be reported. There is also a system called VSafe that I think comes with your information. Pretty sure, Dr. Madden, and that is it's an app that someone who's been vaccinated can put on their phone, and they are in connection with the CDC, and they follow somebody who's vaccinated over time to make sure, again, that they're not having any side effects. The system of VSafe, I've not done it, but it's apparently really pretty easy to use. And again, I think it's incredibly important that we continue to report things. So if you have a concern with someone who's been vaccinated, it's better to over-report than to under-report early on, and to make sure that we are collecting and really making sure that there are no other safety aspects of this vaccine. Again, so far, it really appears pretty safe. I do want to emphasize what Dr. Madden said, is yes, we are concerned about anaphylaxis, and you need to be prepared. It's actually been incredibly rare. There have been 6 cases out of the first 2 million doses given in the United States. So again, an unusual event, but one we need to be prepared for. And Lisa, I know that the questions are sort of piling up, so I will turn it over to you for questions.
Yeah, okay, great. Sure, thank you. And just to underscore one thing, so VAERS is provider reporting, although I think anybody could. VSafe is the patient, right? The patient is actually reporting directly. So just to emphasize that. We do in these slides have a whole set of links. There's this information, recordings are posted to the CDC website, and actually, if we've got a minute at the end, there's a whole new CDC governor's vaccine website that has information on distribution as well. But yes, we're going to break and go to questions, and hopefully they're a little bit easier to see in the chat this time.
One question is, if they have an anaphylactic reaction, should they get the second dose? And that guidance has changed over the last week. Do you want to go through that?
Yeah, and I think Peggy Penoyer I saw is on, and I know Peggy has been neck deep in this. Peggy, I think I saw.
So they shouldn't get a second dose. They can consult an allergist immunologist for PEG testing and specific allergy testing. But this is all very much in right now. They're suggesting no second dose for anaphylaxis, and also not to have a second dose without further consultation with an expert when they've had any milder immediate allergic reactions to their vaccine.
So can you just underscore that last part, because that's new, right? Just in the last week, any immediate reaction to the vaccine. You say more, Peggy?
Any immediate allergic reaction. So
Right. Yep.
Things that meet criteria for hives, true allergic reactions, not vasovagal, obviously, not, non-allergic symptoms to the vaccine, and not just regular local reactivity that is delayed several days. So.
Great. Unfortunately, Dr. Penoyer is now recently retired, so you can't send them to her. But Peggy, in this state, this notion of send somebody to an allergist, like on short notice, right? That's almost unthinkable. So you said you're working with the chapter, and
I think they will be gearing up because this will be coming. And so there is specific testing that can be done, but the dilemma will be what to do with those testing results. So for now, I think if somebody's had a severe allergic or even a minor allergic reaction, they ought to consult with an allergist immunologist first. And I suspect they'll be doing telemedicine and other methods, just to get this done quickly for patients, recognizing the immediacy of the need in the community.
Peggy, do you want to emphasize no steroids?
right.
And that's the other thing is, there was no data for benefit for steroids in treating anaphylactic reactions. So there's no immediate benefit. It's a rare situation. The one that occurred at Maine Med was an asthmatic and needed steroids. But if steroids can be avoided in treating these allergic reactions, since it may blunt any precious antibody response to the vaccination. So try to avoid steroids. Epinephrine is the drug of choice. It works enormously effectively, and that is the drug that should be given. Antihistamines really only treat minor symptoms, and epinephrine is the drug.
And just to underscore that, any provider site, vaccinator site that's going to be administering this vaccine must have epinephrine on site. That is very clear, right, from the US CDC recommendations. And if you can't get an EpiPen, then talk with your pharmacist about other ways to get that. I don't know if Katrina is on. We've got a great pharmacist consultant on our group as well. I'm not seeing her. If practices are running into issues, you could certainly let us know. We can try to connect you, but that's a must. Is that fair to say, Peggy?
Yes. 2
The
doses.
next, yeah, the next one is around wiggle room for the second dose, not getting it exactly at 21 days for Pfizer, 28 days for Moderna. What's the time window?
Ideally, we want to give it as close to the 3-week for Pfizer, 4-week for Moderna. That's the way it was studied. We don't have a lot of data, but there were people who missed their out doses and a few who came in a little early. Recommended if it's gonna go, up to a week afterward is probably fine. Beyond that, it's, again, the emphasis on really try to get people in. If they do come in late, it's better to give them the vaccine than not give them the booster overall. Going too early is probably a bigger issue. It shouldn't go more than a few days earlier than the expected booster time frame.
Steve, the question about, have you heard anything more about the Johnson & Johnson vaccine or AstraZeneca coming to the United States?
They're both in review. They're not ready at the same points as the Pfizer were when you started hearing about them. So I'm guessing by the end of January, we're looking. Those are adenovirus vector vaccines. The one one of them is the AstraZeneca Oxford that's being given in Europe or in England already. Johnson & Johnson is combined with Janssen, and that will, as I said, probably by the end of January. All of the data should be in. Could be a little bit before, but I would doubt that.
Lisa, there's many questions about the phase 1A group 2 rollout, the groups that are not hospital employees. How are they going to get their vaccines in that bigger group? Do you want to, I don't know if you want to go back to the slide that kind of shows it, but just initial thoughts.
Sure, although I just X'd out. So I can try to get that back up. The short version is so phase 1A healthcare providers, right? So everybody's concerned about that in January. Number one, start with, and there's a great FAQ that's a little bit buried on the CDC website, but Amy, maybe you could chat that. I really appreciate everybody chatting all the links and answers to questions. That's really helpful. But I can put that in just a minute when I'm not talking. I'm not really good at doing two things at once here, but it walks through group 1, 2, and 3. If organizations have vaccine, they should keep marching through that available vaccine, but that's a suggested priority. And then the question is, if my organization doesn't have vaccine, how do I get it? Number one, check with your employer if you're lucky enough, to work for an organization that has it. Number two, go to your primary care provider if they are lucky enough to have it. And number three, would be to look around in your community. And we are working on a system that hopefully we will have more details out later this week on sharing information about groups that are offering to do providers who don't work for them, other independent providers out in the community. So Maine Medical Association, again, being very helpful with that, Primary Care Association, and several independent practices. So we plan to have more info on that soon. And I'll link to that FAQ because I suspect not everybody has seen that. Keep going, Amy.
Yeah, I just put the link into the state website that just gives groups. I mean, we're getting a lot of questions around the behavioral health, school nurses, school health. Yes, you fall into that group 2 section of 1A, and there'll be more information, like Lisa said, about how potentially to link you up to some of the sites. You're going to need to travel to one of the sites to get vaccinated.
And I just put the link specifically to the FAQ for vaccine personnel, healthcare personnel that has those 3 groups. And there's a little question, how do I get it? And let's get a little bit more what I just said. Clinical questions. I'm seeing a few more emails, just a reminder that we said now we're doing CME by sending it to an email, and somebody kindly put that in. I'll put it in one more time, covidcme.dhhs@maine.gov.
So some questions around.
Other questions, Amy?
Once you get COVID vaccine, can you still get COVID, the disease?
The answer is yes. It's it is a good vaccine, but it's not perfect. After one dose, it's probably about 50% effective. And there have been cases reported already of people who did get COVID in between their 2 doses. And I saw that Dr. Lichty put up, there's a reference on what to do about that overall. I think the big question that is unanswered with the vaccine is it's very good for protecting against disease. We don't know whether it totally protects against infection, i.e. the ability to carry the virus and then transmit it. So therefore, after vaccination, it is still recommended that masking, distancing strategies still be used, because that's an unanswered question at this point.
Another question is, if you've gotten the vaccine and you've been exposed to someone who has COVID, so you're close contact, you need to go into quarantine.
Yes.
Cheryl, say more.
Yeah. That just, it segues on from what Steve was saying. I mean, these vaccines look to be incredibly effective, and there is some protection that appears to be conferred fairly early after the first dose. I would say that, by the way, those numbers are tiny in both the Moderna and the Pfizer studies. So it's just a real caveat that, after one dose, we don't know that it's such great protection. But even after 2 doses, if you have an exposure to COVID-19, this vaccine is not 100% effective, and you do need to keep doing all the things that all of us need to do or not do if we're exposed.
Great, thank you. Probably time for 1 or 2 more questions. Amy, you seen ones coming up?
There's questions about, you are going to post the slides. The slides are on the CDC website so that people have access to the recordings and the slides. Question about how much Pfizer and Moderna vaccines being produced nationwide, and how much Maine expects to get.
I can't really speak to how much is being produced. You hear lots of different stories in the news. Their goal is to produce up to 100 million doses for each one of those vaccines to make them available. There is vaccine that is still available for distribution. It just hasn't gotten through the distribution channels. And Maine is going to be getting theoretically enough over the course of this vaccination time to vaccinate everybody in the state of Maine. It's going to be done through the phases, starting as Lisa described, the one, and getting into beyond the healthcare providers, into essential workers, and then into the over 65 and those with underlying medical issues. Beyond that, it'll be then available for the entire community. I don't have a crystal ball on saying exactly when that's going to happen, but it's going to be probably later spring into summer before it's available for the general population.
And just a couple of questions. I know a few people are on the phone, so we've had questions about the vaccine is free, but the vaccine administration fee can be billed to insurers. Those codes are being opening up. MaineCare opened up their codes. Medicare has opened up codes. Private insurers are opening up those codes. And then another one is, if you're on an antiviral, can you get the vaccine? And I don't know if you want to give that answer. I see it in the chat box, but just for the people on the phone.
Yeah, being on an antiviral is not a contraindication to getting the vaccine. There isn't really any biologic plausibility for that being a problem, especially because essentially none of the antivirals that people are on day to day are active against COVID. But also, we're not giving COVID when we give the vaccine. So.
And this is Lisa. I'll just do that. I did get my screen, that slide back up in case anybody missed it. So just one more time for all the questions about distribution. And again, this is described in text on that link that I sent, and I think maybe Amy, you sent as well. The link is also here on the slide on the Governor Mills COVID vaccine webpage. We're in phase 1A, healthcare personnel. The intent is to distribute widely and get everyone in healthcare personnel, ideally by the end of January. We started with group 1 that extended to medical practices this week. Will be as soon as we're through group 1, which hopefully will even be in the next week or so. Extending to group 2. Again, if some sites have plenty of vaccine, we've said just keep marching through here. Some 3s will get in ahead of some 1s, and it's just about volume and velocity and getting this out as quickly as possible. People have asked about nurses, behavioral health. Anybody who's not acute care or medical practice is in group 2, and then people who are non-patient facing, meaning back office, they're never in the office, they never touch patients, but they are critical infrastructure to healthcare, group 3. With that, we are just over the hour, so we'll need to sign off. Again, we have recorded this. We'll post it. I put the link to the site where both the slides and recordings are posted. We'll do another round of this on Friday. We've typically done Fridays at 12 noon. We missed the last two for holidays, but we'll do another version of this. I'm sure there'll be additional questions. I'll tweak the slides maybe just a bit Friday at noontime. And then again, next Tuesday, we'll shift the content again a bit. So thank you all. Thanks so much for joining, all of our faculty and experts for joining, and all of you for help answering the questions as well. Take care. See you soon.